Good evening, ladies and gentlemen. My name is Julie Maxton, and I'm the Executive Director here at the Royal Society. It's my pleasure to welcome you all to this event, which is being held in partnership with the National Institute of Health Research, whose 10th anniversary it is this year. Before I begin, I would like to run through some housekeeping announcements. Firstly, that we have no fire alarm planned as a drill, so if you hear the fire alarm with its own distinctive sound, which is the same as anywhere else, then do not go to this door because it doesn't open, either the door at the back that you came through or this one here. Could I ask you to switch your mobile phones off or switch them to silent so that there's no interruptions. And finally, I want to let you know that this evening's event is being webcast live and recorded for the Society's archives. We're delighted to be joined this evening by Professor Dame Sally Davies. Sally is a Fellow of the Royal Society. She's currently the Chief Medical Officer for England, the first woman to hold this post, and Chief Scientific Advisor to the Department of Health. Beyond her advisory role to the UK government, Sally is a member of the World Health Organization Executive Board. She was awarded a DBE for services to medicine in 2009, and in 2013 she was named the 6th most powerful woman in the UK by BBC Radio 4's Women's Hour. She's always strived to strengthen the links between clinical medicine and research, and her efforts include the successful establishment of the National Institute for Health Research in 2006. It has transformed the NHS's approach to clinical and applied research in the UK. Hosting our discussion this evening is writer and broadcaster Vivienne Parry. Please join me in welcoming our speakers.
How great to be here, and what a great audience. Royal Society, NIHR, a marriage of science, health. It's a perfect place in which to talk to you. So the NIHR 10 this year, an extraordinary achievement in itself. It's come such a long way in such a relatively short time. How did it all begin? Because you arrived at the Department of Health in 2004, and such a thing did not exist. Tell us first, what was there when you came?
Well, the story actually starts back in, someone else will know the date, 1991, with a House of Lords report that really the NHS, for what it was doing, was not getting the research it needed. And the then government established the NHS Research and Development Programme, R&D programme, with about £100 million as a national budget to be spent in areas that mattered to patients and clearly of high quality. Along the line with the separation of purchaser and provider in the mid-90s, people became worried that research in the NHS was getting very squeezed. So we, out in the NHS, all completed a declaration about how much time and money, therefore money, it was monetarised, was being spent on research. That was known as the Collier Declaration. So when I arrived as Director General in 2004, in charge of research, I had a nominal budget in the NHS of about £400 million, which was this Collier Declaration, but it went historically to hospitals and we didn't know what it was spent on, whether it was high quality, and
Or whether it was indeed spent on research at all.
well, actually that's one of the big questions. We never knew. And we had this central programme. And arguably we had also lost our lead that we'd had in the middle of last century and going forwards in clinical research, because clinical research had changed from being kind of solo subject to being a team subject based on platforms. If you think about genomics platforms and methodologies and randomized controlled trials, you need specialists in many areas. And we hadn't kind of kept up with that. So it was important that we addressed the historical unfairness of where money was, that we made it work for research, and that we discovered our platforms and our ways of doing it.
But when you talk about the unfairness of where money was, there's always people who think, oh, it's absolutely fair that I've got this little pot. And so I imagine when Sally Davies marches in and says, actually, it's all going to be different now. There are going to be different ways of holding budgets and different ways of funding this. You might have faced a bit of opposition.
There was a little bit of pushback. One chief executive was getting £56 million a year. And
not personally, we hasten to add.
No, to his hospital. Another was getting 35 million. And what we had to do was explain to them, and I was not alone in this, the department was very strong, that this was a government policy to introduce the NIHR. Patricia Hewitt, the then Secretary of State, had been Science Minister, Minister for Women. She got it, and she was very supportive, took the whole strategy through the cabinet, so it was a government policy. And then I would kind of come in behind my finance colleagues who'd said, well, it's government policy, and say, anyway, if you're as good as you say you are, you're going to win it all back. So don't worry about it, because it's all going to be available for competition.
Ah, hoist by their own petard.
Afraid so.
So that all went through, and the difference in budget between now and then, you now hold, or the NIHR now holds, something like £1 billion a year.
It's 1,178 million, and on April the 1st, I handed it over to our new Chief Scientific Advisor, Chris Whitty, on the front row, to run. Yes, it's a generous budget, and I think we were given it because we demonstrated to successive chancellors that A, we could manage it effectively, very transparently and very effectively, and B, it delivered what we said it would.
And have the detractors at the time now come round to the idea?
Oh, yes. They came around within about 3 years, actually.
So tell me exactly what NIHR does.
So it is simple. We have an NHS, which is a health system, and what we have overlaid and integrated is a health research system, and it has a number of parts. It has infrastructure, like our managed clinical research networks, which support people wherever they are, whether they're patients who want to join in studies, whether they're clinicians, and by clinicians I don't just mean doctors, nurses, dentists, occupational therapists, clinicians to put patients into studies, experimental medicine facilities, our biomedical research centres. It supports training. We have a budget of £56 million for training young doctors to be researchers of the future. It supports our systems, the ethics committees to protect patients and things like that. And then finally, we have a budget which is known as the market failure budget, because when we were working up our plans, I got in some young men, they're always men, very bright from the Treasury to challenge me. And they said, you don't need a research funding budget. And I kept explaining I did. And eventually one of them said, oh, yes, it's market failure. Oh, all right, you can have a market failure budget. And by that, what we meant was it was research that the service needed that no one else would fund. So we have a massive clinical trials portfolio, comparing off-patent drugs with each other, painkillers against hard beds for back pain, physiotherapy early or late, all sorts of things that no one else would fund, yet we and our families as patients need that evidence.
So one of the most important trials I think that NIHR has done is the CRASH trial. Tell me about that, because I just think that this is such a fantastic example of how NIHR really delivers the goods.
Well, I think it's very interesting. So the theory when I was a young doctor was that if you had a head injury, your brain would swell and that would give you brain damage and kill you. But from animal models, we knew that if you gave high-dose steroids, the brain wouldn't swell as much. So, theory, you do that and then people won't die. So we all gave steroids. Along came the researcher and said there's equipoise. Actually, we don't have the real evidence. We funded the trial, and I'm talking about a different trial, aren't I?
You're allowed to. I'm going to talk about the right trial in a
Well, I'll
moment.
finish this one because it's really important. We did the trial, and actually, patients I looked after must have died because I gave them steroids. We didn't need steroids. The one you asked me about, the crash one, was actually tranexamic acid, and it's
Yes.
a similar sort of story.
So tranexamic acid, if you ever have problems with periods, that's what you take.
It stops you bleeding, it clots.
I'm just worrying about your
clots
audience
people
now.
up. But if you've got renal problems, you don't want it.
Yes.
Because you can get a blood clot in you. Yeah, and knock off your kidneys. So just get medical advice from someone good. So, question. If you clotted the blood of someone with brain trauma, would they have better outcomes? Randomized controlled trial, masses of patients in it. Quite simple answer, you save lots of lives. Yes. And then the researcher was fantastic. He got it into the MOD and the theatre of war before it was even published, and into the ambulance service really fast. So that was not just nice research, and tranexamic acid, as you know, is
it's cheap as chips.
Yeah,
Yes.
but it also was translated into the NHS extraordinarily quickly. It's a really nice story.
And one of the other things that I love about NIHR is the Eye for Eye programme. So tell us about the Eye for Eye programme, because it is, you know, I used to do a programme called Tomorrow's World a long time ago, and it just is the stuff of dreams for, you know, BBC journalists, because it is technology that is just so fantastic, and people look at it and they think, I get it, that's so amazing, and it is.
It is great, and the director's in the audience, so he can be nabbed to talk to it, but essentially people can apply, and it's generally academics, with an idea for a piece of technology. One I rather liked that got onward funding was taking people who are almost blind and giving them specs so that, not that they get their vision back, but so that they can live a life because they can see shapes and they can cross roads and be safe. All sorts of really clever gizmos that, you know, someone's thought up, but then they need the money to try it out and see if it works. And then one of the beauties of this program is the entrepreneurship training that Martin and his colleagues have put in to help people go out and get the follow-on funding. I think one program got an extra 20 million? 29 million, you know, from a small amount of money from us, seed funding. Isn't that wonderful?
It is extraordinary. So it really has doubled the research efforts. It's got it out there, which is after all what it's about. No good doing research unless it actually gets into patients' hands. So just let me take, so you have this job reforming and setting up NIHR, and you also then have a job as Chief Scientific Advisor to the Department of Health. So what does that involve?
Well, every Chief Scientific Advisor across government, and as you know, there's one in most departments, and
Even
a government
Treasury.
Yes, there is actually an economist, isn't there? Yes, and there's a government Chief Scientific Advisor. Plays it out differently, but the idea is that you're there to offer advice and find evidence for the development of policy and for the evaluation of policy. And as we know, many policies of all governments, so this isn't a plug at any particular party, introduce ideas, but then don't start with pilots and evaluate them and roll them out. They say, I know well what'll work, and put it in place. Even then, you can do step wedge, you can do methodologies to evaluate them. So the Chief Scientific Advisors advise both on the evidence to underpin policy and the sense behind them, and then on how you'd evaluate and see whether you really want to go on that way.
And then, so there you are doing the Chief Scientific Advisor's job, you're doing the NIHR job with a budget of £1 billion, and then you're asked to be Chief Medical Officer. And a lot of other people, Sally, would have thought, do you know, I've got two jobs, I really can't take another one on. I've got two jobs that are full-time in themselves each, and now here comes another one. What made you decide to go for the CMO job?
It was a mixture of things. I reported to the CMO, so I was frankly worried, gosh, what CMO am I going to get, and will they try and clip the wings of NIHR so we can't do the things we know need doing? And yeah, I like challenges. My family always wonder where the next Everest is, and I thought it would be very interesting, and I would learn a lot, and I want to make a difference. Maybe there were ways I could make a difference.
And in the CMO position, you've done not only the domestic agenda, but I particularly wanted to talk about the things that you've done on an international stage. Because I think people perhaps don't realise how you're viewed outside Britain, particularly because of the way that you've led on antimicrobial resistance. How did that antimicrobial resistance story all start? What made you think, actually, this is a really serious issue? Because it's now in there in the government risk register. I mean, people say, oh, it shouldn't be up there with terrorist attack, but actually...
More people die of it than will of terrorist attacks.
Yes. So, but what made you think that it was the issue that it's become now?
I didn't expect to end up doing this. But one of the pleasures of being the Chief Medical Officer is I'm an independent advisor to government, and I'm expected to write an annual report. And we reviewed all the annual reports going back 165 years to see how people had done them. And there were two parts to them. One was putting health data in the public domain, and another part was advocacy. So I decided that I would do a volume each year putting health data out there, but try and show it in new ways with infographics and cartograms and things, and put different data sets beside each other. And do a second by choosing a subject that I thought would be interesting and getting the experts to write chapters. And then actually my role was to choose the subject, check the chapters were what I wanted and that we'd got them all, and then writing the policy implications of that. So I thought we'd start with infection because it's important in primary care, hospitals, even the most specialist hospitals, and in social care. And I actually thought, it shows I wasn't expert, that this was not going to be contentious. And when we came to the workshop at the end of everyone writing the chapters, and I said, so tell me what you've written, and what is it you're worrying about that policy needs to do something? One after another, they talked about antimicrobial resistance. And I explored it. I am a haematologist, a blood doctor, and I stopped seeing patients in 2006. So this was 2013 or the end of 2012, 6 years later. And it was absolutely clear that when I'd looked after patients when I was young, we got some resistance developing naturally, and we had new drugs at that time when I was young. But the new drug pipeline had dried up and resistance was going up and up. So I said to these experts, I said, so this sounds really awful. What have you done about it? And they said, oh, we keep telling people. And what I realized was the experts had not got a voice. And yet this was a growing and very severe problem. And as we know, it takes at least 20 years to develop a new drug. So if we don't do something about it now, our children and grandchildren will live in a very difficult world. So I felt I had to do something about it. So I wrote the recommendations on policy to reflect that, which included putting it on the government's risk register, and everything else followed.
And how persuasive did you have to be in order to get it on the risk register? The case had to be built, and in the Department of Health, our analysts built the case around the economic impact. And actually, once they built it, it went through quite easily. It's just that no one had thought to look at it from that perspective. And you've taken that on a global stage because, of course, this is not an issue that any one country can tackle alone because it is a global problem. How have you developed that work?
Well, I represent the UK on the WHO's executive board, so I said to the WHO, clearly this is a big problem, let's have a resolution. To which they said, oh, come on, Sally, we've had 2 or 3, it takes 5 years to have a resolution. And then look, where did the ones before get us? So I said, we're going to do it differently. We're going to have a resolution that mandates action, and we're going to do it next year. And the Director General, Margaret Chan, was very supportive, so we talked around and we found that particularly Sweden and the Netherlands were very supportive. And between us, we did the diplomacy and got through a resolution in 2014, which mandated the WHO to build a global action plan for for 2015 that was accepted by the whole World Health Assembly. And then one of the beauties of this is the whole government has pulled together. DFID took it to the Food and Agriculture Organization of the UN and got the same global action plan agreed by them. And DEFRA took it to the Organization for Animal Health in Paris and got the same one through them. So we had the 3 global organizations with the same global action plan saying, we're going to do something about it. And would you believe, now, so that was 2015, summer 2015, we're going to the UN General Assembly for a high-level meeting in September, a health issue being discussed by prime ministers and presidents.
That's an extraordinary achievement, and you've been the one who've been shepherding this forward. How difficult has that kind of diplomacy been? I mean, I always get an impression of, lots of people, dark, smoky rooms and staying up till 4 a.m. Is it like that?
I think some of the diplomats may do that. My role is about the advocacy, the passion, the explaining. I've just come back from Japan, where Japan, as president of the G7, asked me to go and talk to 18 health ministers from their region of Asia. And so my role is that, to say, it looks complex, it's a whole system, whole earth issue, but we've got to deal with it and we have to bite it off in chunks that we can do. And thinking about what can be done. And then the Foreign Office, DFID, the Treasury help. But of course we've been greatly helped because the Prime Minister, at my request, commissioned Jim O'Neill, who had been the chief economist at Goldman Sachs, to do an independent review of this. And Jim started saying, well, this is quite interesting. And after a bit, when he looked at it, he said, this is really important. We've got to sort this. And since then, his final paper comes out mid-May, but since then he's become a minister in the Treasury. So I've got another champion over there helping in government.
You need all the friends in Treasury you can get.
Absolutely, yes.
But how difficult is it? Because we know that kind of Armageddon type warnings to people about antibiotics don't work. There's a culture of people taking antibiotics or wanting them, partly because it validates their illness. Oh, he gave me an antibiotic, it proves I'm ill. But how difficult is it to get that message across to ordinary people without scaring the bejesus out of them or really not getting them into action?
So it is very difficult, and we have to go at it in multiple ways. I mean, first of all, you need good sanitation and good hygiene. We've got to prevent people getting infections, and hand washing seems to need to be taught in hospitals year after year. We never remember the lessons forever. But then in the over-prescribing in the human sector, it's, as you say, both patient demand and clinicians. And it's a very difficult issue for a clinician. You've got a sick child in front of you. You don't think it's a bacteria that will respond to an antibiotic. It's probably viral. But the mother is demanding, and it is a clinical judgment. What we really need are rapid diagnostics. And of course, thank you, public, for voting for antimicrobial resistance, a rapid diagnostic, to be the subject of the Longitude Prize, because that's also raised awareness. But also that means there are a number of groups trying to make a rapid diagnostic to help doctors.
So this would just tell doctors immediately this is either an antibiotic-resistant one, so don't throw any more at it.
Either virus don't give it, bacteria do, or this one's resistant, so you better use another. But you can do behavioural things. So working with that Behavioural Insight Unit, we tried just over a year ago, sending a letter to half of the top 20% prescribing GPs. We didn't say you're doing a bad job or anything like that. Who's to judge that when you're not there? We said, you are prescribing more than most GPs. Here's the picture and here's where you are. And immediately their prescribing dropped as they began to realise they were above the norm. And then at 9 months, when we told the half that we hadn't written to that they were in high prescribing, they dropped as well. And it's persisted. It's quite interesting. We can help people in nice ways, with nudges.
How do you hope that the antibiotic resistance story will play out?
I think we need a number of things, and the UN General Assembly meeting will help with that. We need to make it much more difficult to get antibiotics so that you're given them when you truly need them. You would be horrified about some of the stories of hospitals abroad where you walk in and you're given 4 intravenous antibiotics immediately. We need to phase out antibiotics in animals and fish farming for growth promotion. So the story goes that if you have a farmed salmon in the States, it has eaten its weight in antibiotics before it comes to your plate, because they just tip antibiotics into the feed.
It's truly scary.
It happens with chickens in many countries. I mean, it is horrible. And we have a massive reservoir of antibiotic resistance in these animals. But we also have to balance access with excess. So more people die of the lack of antibiotics reaching them at the moment than die of excess. So we've got to sort that. And then finally, we need new innovation, better surveillance so we know what's happening around the world, new rapid diagnostics so we know when to prescribe, and to sort the market failure so we make new antibiotics, the R&D right through. And that's a lot of the work that Jim O'Neill's final report is going to focus on.
Just to go back to the beginning where this question started, was there a single fact that kind of tipped you over into thinking this is critically important?
Yes, the fact that no one was doing anything.
Because we so rely on, we've forgotten how much we rely on antibiotics. I mean, you know, my life was saved by antibiotics, my son's life was saved by antibiotics. And we've forgotten that actually people who are in remission from leukemias,
if
people
we lose
who
them,
have cancer
cancer care, transplants, routine surgery, forget it. Forget modern medicine. It's going to be a disaster. I've written the book too, as you know.
You've written the book as well.
The drugs don't work.
That drugs don't
And on the TED Talk.
So let me now just go back. Those are some of the things that you're best known for, I guess. But let me just take you back to where you yourself started. What made you want to be a doctor?
I was the daughter of academics, but I don't think that made me want to be a doctor. I was fascinated by the double helix, actually. So I sat in the 3 interviews I had for medical school, and they asked, and I said, the double helix. And here I am, you know, really interested in genomics, and my research was in genomics too. So it was that, and the fact that I like people, and I wanted to make a difference.
It's double helix. That was the very thing that sparked me into science as well. And this morning I was with 200 school children showing them that there is 2 meters of DNA in every cell. And they didn't believe me. Really? It was fascinating to see how they were gripped by this extraordinary molecule too. So you went into medicine, but then you left it, didn't you?
I did. I trained in Manchester, which was a great medical school, and did a couple of years. But I found it very hard. I graduated at the age of 22, which perhaps is too young. And in those days, I found it quite brutalising. There was rationing of renal dialysis, and a young woman I looked after at age 22 was not allowed dialysis, and she died in my arms in the middle of the night, drowning in pleural fluid. I mean, so things like that hurt me, and we didn't have good support for young doctors. We had each other as young doctors, and everyone did their bit, but I found it hurt the inner me, and so I got the opportunity to marry a diplomat, and I went off to live in Spain for 4 years.
I can't imagine you as a diplomat's wife, Sally.
No, I wasn't very good at that stage.
What in the diplomacy stage?
Yes, but I did learn good Spanish, and the Spaniards all quite took to me because I was entertaining.
So you did actually go back to medicine. What drove you back?
Well, I missed it. And I think there are so many wonderful things about medicine, but one of the great things is there are many different careers. You can find you know, you may not like patients and be good at physics, and you can go and do nuclear medicine, you can be an imaging consultant. You can do so many things. And I thought, you know, I shouldn't be put off. I should go back, and I was 4 years more mature, and find the right thing for me.
And it was haematology.
That was by chance. I wanted to be a paediatrician, so I got a paediatric job. I did some retraining. I got a paediatric job, and then it was clear that coping with the nights on call and marriage was rather difficult. So I then swapped over to haematology and liked that.
And you went into sickle cell disease, which wouldn't have been a popular choice at the time. It was working with patient groups who were very marginalised, who really needed to have a champion, and you became their champion.
Yeah, they're wonderful people, and it was fantastic because it's an inherited disorder, and I would look after granny, son and grandchild. And they're just, I mean, I still get emails from my patients, and I haven't seen any of them since, you know, except occasionally socially at a sickle cell event, since 2006. Fantastic group of patients.
So, just go back again to you started doing R&D, really. I guess you got bought in, first of all, locally, then you worked your way up and you'd become chairman of the R&D group in London. How did that transition go? Because it's quite a tricky place to be. A lot of clinical academics really don't like that area.
Well,
and
having seen colleagues who knew me at that stage in the audience, I will, as always, choose my words carefully. I was clearly quite good at some things, but not good at everything. And one of the difficulties was that London had 57% of the supposed R&D money, and there were 8 other regional directors all ganging up on me saying, this isn't fair, you've got to give us some.
And were they all men?
There was one woman, but the rest were men, yes.
We'll come back to this.
And I took a line, which I still do, is if you can show it's better spent somewhere else, you should move it. But you can't show me it's better spent, so we can't move it. But it was quite difficult, and they kept kind of beating me up. So eventually I went to my regional director and I said, and you know this story, we have a choice. I burn out, I leave, or you pay to train me. And I'm not burning out, so are you going to pay up and I'll go and get some proper management training? And he said, I'll pay. So I went to the European Business School.
Yes.
No, I did offer to leave after all. It was his choice. I think they probably think now it was quite a good investment, but they sent me to the European Business School for a 3-week course on emotional intelligence.
Ah, and so is that the basis of your success with globally?
Yes. It absolutely is, because I remember about a year later, one of my regional director colleagues, after I'd done this, saying, I don't know what you did, but you used to get in fights, and now you're not getting in fights, but you're getting your way, aren't you? And I said, no, of course I'm not. But the other thing that was very interesting, it was emotional intelligence on the Freudian paradigm, 20 men and me, 20 private sector and me. So it was a very interesting course.
I said that I'd come back to it, but the whole thing about women in science, and you did something which I think women scientists cheer you on for still. So you saw that there were very few women in clinical medicine, and you were fed up of there not being enough women in clinical medicine. And you decided to take some action. So just tell that story of what you did.
So it started with an external panel 5 years ago, a global panel, doing 46 interviews of partnerships between hospitals and medical schools for £800 million. And the panel asked the gender question, what are you doing to help women in science? And the NHS chief execs were kind of okay. And then the universities varied from kind of okay to well, you know, over half the medical students are women, so when they come through, it'll sort itself out. To the surgeon who said, well, over half the team are women. And there was a silence, and I thought, yeah, bottle washers, floor cleaners, nurses. And he filled that silence with, and I really like having them around.
Well, they're fragrant and
Yeah.
add colour.
And I was not incensed at the time. I think I became incensed later as I thought more about it. I was just horrified at the lack of appreciation of half of the workforce. So, and the panel were disgusted. So I thought about it, and of course, what we haven't talked about is why is NIHR a success? And it's a success because it's a great plan. But Russell Hamilton, who's just retired, was central to that. And I went to see Russell, who I trust with my life, and I said, Russell, I want to send out a letter before they know whether they got any money, and I want to tell them that next time they come back for this funding, they must have an Athena Swan Silver Award.
What do you explain what Athena Swan is?
Right. So it is a charter mark, and universities sign up to the charter, and then they by departments or schools, apply for bronze, silver or gold. They get visited to see if they're of a good enough standard, and if they are, they get that. So I was expecting the whole university to sign up, and then the medical section to get to silver, and 5 years. And Russell, who I trust absolutely, said, I'm going to have to think about that. So you leave Russell alone to think. And a couple of days later, I said, have you thought about it? And he said, well, yes, you could do it. And I said, do you think I shouldn't? He said, no, that's not what I'm saying. I think you could. So I said, oh, well, the more I've thought about it, the more I think I have to do this. So I sent the letter out. The next day I said, I did it. And he said, yes, I know. I think that's going to be one of the most important things you do. And I said, why didn't you say that? And he said, because you had to do it. So, but he helped me manage it. And then started, of course, some of the rudest letters and phone calls in my life.
Never upset a Vice-Chancellor.
Well, one of them got back at my request I said to my office, just send him a letter saying, the CMO's noted your letter and asked for it to be filed.
So it must have been a very rude letter.
But
it had an extraordinary galvanising effect. Vice-Chancellors, to a man, hated you with a passion. Women in medicine cheered you to the rafters.
But it's not only medicine. I was on a visit a couple of years ago to Scotland, and this woman physicist hugged me, and I said, I only look after England. You're not even medical. She said, the ripple effect.
Yes, it has. It has.
I mean, it's fantastic. I'm so pleased.
And just explain what it's done now.
Well, I mean, the universities, once they believed it, and that did take a year or two for some of them, then got on with doing it. And that meant they had to think about half of the workforce. They had to think about the economic impact of not harnessing that workforce, how to support them. And you know, if you get it right for women, you've got it right for families, for men too. So it's not just about women. And some of them failed. They didn't get their awards.
Because they thought it was going to be just a tick box. And they didn't really have to do anything.
No,
they just kind of had to sort of
and
look
it's empowered lots
good.
of women who said, come on, we're not going to get the money if we don't do it, so you're going to have to. And they took by the nose their bosses, their professors, and made it happen.
And do you think now that women are on the rise? I mean, you've that very nice thing about being 6th on the Women's Hour Power List. I don't know whether that makes you feel powerful, but but do you think that women, the situation is now changing, or do you think actually in pockets it's still as bad as it ever was?
I think in society it's improving, but there are still bad pockets. And it's such a pity because when I started on this journey, I have to say I didn't quite realise what it meant when I imposed it, but I'm glad I did it. I was in York, and I think it's their chemistry department that was the first to get the gold.
That's right.
And the professor said, you know, it's fantastic. And I said, why? Are you getting all the best women? He said, yes, and all the best men. Because they want to be where the good women are and where the policies are open and good. So I think it's taking medical teams time to understand that, but they're getting there. A lot of people are quite happy.
And you yourself, as a woman, have scored some notable firsts, not least of which, of course, is being the first Chief Medical Officer in how many years?
165.
In 165, which is quite an achievement in itself. What are the things, going back to NIHR, because now here you are, you said that you would hand over in 2016 your baby, NIHR, to someone else, and that you would be around to mentor that person as they took on the role. The wonderful Russell Hamilton has now gone off backpacking in Australia or somewhere. But that's sort of, it's closed a chapter, that's 10 years, and of something that you started, you drove through, you've left as this hugely successful, globally admired organisation. And I wondered what it was that you were most proud of in NIHR.
I think it is the whole of NIHR, and let's not forget all the people in it, many of whom are here. We couldn't have done it without Russell and the team in the Department of Health, but then we have these commissioning centres in Leeds, in Southampton and a couple of others who do fabulous work. Then the research teams joined in and really made it work. And as for our research networks, what a fantastic job they do. So it is, for me, my pride is how we've all pulled together to make this happen. And I think it's just wonderful watching how, if you work together with a shared vision, what you can do. You can move mountains. We have, the NHS.
So NIHR has been a huge achievement in your life. AMR is a continuing story. We haven't seen the end of that particular story, but it's moving towards a much better place than it has been in the past. Is there anything that you would like to have tackled that actually hasn't worked out quite as you would have wanted, or remains uncharted and unconquered?
I've used my annual reports to try and get at a number of difficult issues. So women's taboo issues, as you know, was the last one in the autumn. Mental health, children's health, and I'm very proud at both the work in those documents, but actually at the impact they've had. My present one is on a subject close to both our hearts. It's on genomics. And what I try and do with these, and this genomics report looks as if it's going that way, is kind of get into the difficult areas and lay out the issues and make some recommendations to move it forward so that we in Britain have solid principles on which we base our work and take some action. And I'm very excited about that one, and I'm now thinking, what will I do after that? And I haven't yet decided, though I've got some thoughts.
You said that you were always fascinated by DNA, and it is an extraordinary molecule. What was it, though, that made you such an enthusiast for the 100,000 Genomes Project?
So the Prime Minister announces we're going to sequence 100,000 genomes. DNA is magic, isn't it? We have it in all our cells.
2 metres of it.
It makes us who we are. As we learn more, we know that the genes don't change, but how they're configured, the epigenetics changes. It goes from parent to child. And actually, with the epigenetics, that debate about nature versus nurture has come alive again. I just think it's perpetually fascinating. I think for science is, but genomics is one area where I know quite a lot and I'm fascinated.
And what do you think it will deliver to the NHS and to the UK?
I think it has a lot to deliver for patients. I mean, we already do offer prenatal diagnosis of fetuses so women can take an informed choice. Do they want an affected baby in sickle cell? And that we've provided that service for many years. I think it will lead to some treatments. I mean, I was discussing with Doug Higgs from Oxford when CRISPR-Cas 39 or whatever it's called will come in to use stem cells taken from someone's bone marrow to manipulate it and give it back so they don't have sickle cell disease. I think we are already seeing the fruits in cancer of being able to look at the cancer cells and say, because of the genomic signature, the molecular signature, those treatments won't work, but that will. That's fantastic. And as you know from the 100,000 Genome Project, people with rare diseases, many children go on what's called a diagnostic odyssey. They go around doctors and have tests for 2-3 years, still don't get a diagnosis. Whole genomes, and a number of them get their diagnosis like that. And then we found we can change lives with different treatments, which are already there. So it's fantastic.
And how I was very struck when the project was announced, and there was a meeting at number 10 for everybody, and we had patients who'd benefited from that molecular diagnosis. And one of them was a patient with CML, chronic myeloid leukemia, the disease, a blood-borne disease or blood disease that actually caused the death of your second husband. And for you to see something that is now contributing so much to preventing the deaths of other people in that same situation must have been a very personal and affecting moment for you.
It was. I mean, I remember when the paper was published showing that this new treatment could send into remission and give people many years of healthy working life, family life. And it was so impressive because it was the first time that we'd been able, as a scientific community, to look at a molecular problem and then design the drug, which is a tablet, to work on it. That I stopped the regional executive meeting and said, I've got to tell you about this drug because it's so innovative and it's changing the face of medicine, and there will be more. So I gave them a tutorial for 10 minutes on it.
And the 100,000 Genomes Project will deliver more of those
Absolutely.
sort of drugs.
Yeah.
Extraordinary.
Absolutely.
So we've talked about your global challenges. What are the domestic challenges, the public health problems? Because, of course, the role of the Chief Medical Officer is the nation's health. What are the main challenges that we we're looking at and how to tackle them?
Well, clearly they're the lifestyle ones. Do we take enough physical activity? Is our weight controlled? Do we smoke? Do we drink too much? And the way I've gone about that is to try and make sure that my advice, and let's remember it's only advice, is evidence-based on the latest science, and to contribute that either through guidelines to the public or through advice within the department and to ministers.
And how does health research and academia have to step up to meet these challenges?
Well, we've been very good at the biomedical. What we're going to have to get into is much more of the behavioural and understanding. Why is it that before I came down here, I ate a couple of chocolate biscuits, when I probably only needed one?
Well, you luckily couldn't eat them all because I'd already eaten two.
And we need to understand behaviours and how to nudge people, and then think about what is the best way to make that happen so that we know we live in, for instance, an obesogenic environment. How can we modify it and help people lead healthy lives so that they have a healthy old age? Because it's so sad if they don't.
And that's a notable thing that you've done actually in NIHR. You brought far more social scientists and people who are experts in behavioural change onto the research side.
And we did it in Ebola. So Chris Whitty, who's taken over the R&D portfolio, and I worked together on Ebola. He was leading the DFID response, and we had in social scientists who were able to tell us not only that the major spread of Ebola in West Africa was at funerals, but what were the practices in funerals that made it happen. And then they were able to help us understand and people to work on the ground with the communities in an effective way so that there was an appropriate response from the families to the death, but not a response or a mourning that put them at risk.
You've done quite a time as Chief Medical Officer. I wouldn't dream of saying that you're close to retirement.
No, I'm not.
There's many good years in you yet. But the next CMO, what bit of advice would you give to an incoming CMO?
Stick to the science.
That's it. Stick to the science.
Oh, and talk to people. I mean,
and get Treasury on your side, presumably.
Well, yes. So there's all sorts, a whole list. Yes, but I think we are on dangerous ground as independent advisors if it's not science-based. And we do have to learn how to communicate. So as you know, I led a lot of the communication about Ebola. I led the communication for government about mitochondrial transfer and those dreadful diseases. So you have to learn to communicate as well.
And the future CMO might be in a place where we're outside Europe. And what that might that mean for science?
Heaven forbid. I care passionately about Europe. I have a Dutch husband, and that shows you he is the expert in the country on his bit of medicine. Without our foreign colleagues coming to this country, we would be depleted of expertise. But in many ways, but actually in science it's very important. We get out much more money than we put in. That's good news. It helps keep us high in the global stakes of science and health science. In particular, it's contributed to building big networks and platforms across Europe, which mean that a lot of our science is much better than the other place over the pond that tries to do big science. We would be much poorer in many ways, including, you know, our healthy living. Air pollution, beach cleanliness is set by European standards. There are many reasons why I want us to stay in.
And is there a big interplay between chief medical officers of other European countries?
We have a meeting during every presidency, so twice a year. It's interesting that most are much more in a managed system and don't have the independence and the scientific background that I have. And I do think that government would be sensible to replace me when I retire with someone with a strong science background.
Yes, I was going to say, how important has that science background been to you as CMO?
Oh, very. I mean, if you take Ebola, you have, as an example, you have to have formal set piece committees, and most of the advice comes through that. But what I was very keen, and I know people knew that, was that if someone thought there was something new or some wrinkle on it that I might not know, that they sent me an email or rang me up. You have to understand the science, you have to be open to the scientists and know who to ask.
We're close to the end now, but what I wanted to ask you, because I could not ask it in this hallowed hall. You became an FRS. How did you feel when that was awarded?
Gobsmacked. I never expected it. I never even dreamt of it. It is the greatest honour a scientist can have in this country, and to be one of the fellows for me is a moment of total pride. And then when you come to the ceremony, they do it so wonderfully, and you come up onto this stage and you sign the vellum book, which Darwin and Pepys and everyone has signed. It's very humbling.
And as I recall, you were somebody who actually said that she couldn't be a laboratory scientist because she was always messing up her experiments.
That's
and
right.
Here you are, an FRS. And actually, I suspect that, like many things, there's a moment of what I would call imposter syndrome. What am I doing on this stage? You know, in the hallowed halls of Isaac Newton. when I really can't do laboratory experiments. And yet, Sally Davies, you have done so much for science. You've made an extraordinary impact, not only in the UK, through the development foundation and the flourishment, if I can call it that, of NIHR, but also on a global stage, where actually you've taken a really pragmatic, diplomatic and scientific view of the world's problems and pushed through not ideologies, but actually solutions that will work for everyone globally. And that in itself is an extraordinary achievement. And as a woman and as a devoted admirer, I salute you, Sally Davies.
Thank you. Very kind of you. Rather humbling, actually. The imposter is here, I'm there.